front to that.
Go ahead. This is your work first. All ABC भर देते ये जी
जीवन है, इस जीवन का यही है, यही है, यही है रंग रूप। ये जीवन है, इस जीवन का यही है, यही है, यही है धूप छाँव। यूं न सोचो जीत है, ये जिद छोड़ो, यूं ना तोड़ो, हर पल एक अदरपन है, ये जीवन है।
Wonderful, so 1 minute soul connect plays that can be described and some that can only be felt. A woman's journey in ophthalmology is one such path woven with quiet strength, unseen sacrifices and a soft glow of resilience. Only a woman knows the soul connect behind balancing a patient's healing and her own healing, motherhood with midnight emergencies, family duties and surgical precision, dreams with discipline and expectations with excellence. The Women Ophthalmic Society has given us a space where these unspoken emotions finally find a home, a platform where hearts connect before hands do, where journeys intersect and courage multiplies. And for creating this space of empathy and empowerment, we thank Dr. Mohita for building not just a community but a sanctuary. Today we celebrate every woman ophthalmologist, the multifaceted soul who heals with her hands but touches lives with her heart. Here's to our soul connect, a connection that cannot be penned down, only lived, felt and cherished. Thank you so much.
Lost, yet a fortune gained. Many a harvest lost before your hunger is conquered. How about one where the last shred of pride is shed, the last vestige of ego dropped, sometimes before a heart is won. True that a man has to lose, a man or woman has to lose for humanity to win. And in life, many a battle fought and lost before we truly win. Thank you all.
About the predicting the future, but it's about the possibility of detecting the visual problems in the children's eye and educating the parents. So as we know that many cases of childhood visual impairment, they can be prevented, and for that, as we know, unfortunately in the peripheral parts of the India, we do not have access to the pediatric ophthalmologists. So this is where the AI can be game changer because it can act at every step, from early detection in school screening programs, in neonatal units, to diagnosis of refractive and strabismus and parent education, which is turning from limited opportunities to limitless opportunities for the pediatric eye care. So when we talk about the prevention, the first step is smartphone photographs. There are certain studies which are done by Leaks and Ortiz et al. Who have shown that AI model can detect myopia, strabismus and ptosis with great accuracy just looking at the videos or the photographs. So when we talk about AI in myopia, using the children data like ageal length, environmental factors and family history, the AI can predict the onset of myopia as well as progression of myopia in children. So the following two studies, they have shown that the prediction of AI, myopia onset 1 to 2 years before the clinical diagnosis by the high-risk cluster children and which can help in public health interventions and policy decision making. So the AI can not only diagnose strabismus but quantify strabismus just looking at the photographs and the videos. One of the studies which was done by a girl, they have shown that strep next CKO, it's a deep learning model which is doing the same thing. And not only strabismus, very personalized vision therapies and adherence to amblyopia therapy and personalized amblyopia therapies, they are now being all done on the basis of the AI. So this slide is actually very sensitive because nowadays parents are turning to internet before turning to the clinicians, and the AI modules they are turning as their first counselor because the information on myopia, lazy eye is now very easily available on these modules. So one of the studies we have done recently, it is published in AGO International, where we actually compared the AI modules on what kind of information they are giving to the doctor has, which defines the doctor. AI cannot do that. So coming full circle back to where we started, AI can screen, analyze and educate the parents, but when a child is reluctant in the OPD to open the eyes and the parents are waiting outside the OT, that gap of silence is filled by reassurance, and that is only done by the doctors, not by the AI. So we are not replacing the intelligence with codes, but we are building a future which is augmented empathy. So in the end, we may remember we are embracing AI in the pediatric ophthalmology, but that's what truly heals the vision. Thank you.
Closure happens from the central area to the peripheral area. All the years we have been concentrating on the trapezium network and area which is wide and trapezium network which is compressed. What is happening to the nervous system? We have not been able to explore it to get the section, but even then we have been able to do it with SSOCT, UNESCO. I think we will be able to collect all the information as efficiently as the UNESCO. For special situations where four-wheel UNESCO may not work, that I cited, that if a patient in nystagmus, patient has got Parkinsonism and head nodding, and if we want to see angle very so the two-mirror eye electrode, it's up to you whether you are comfortable with two-mirror or pressure is coming down. What more satisfying position can be. So in that way, that critical situation, many patients have got a diabetic retinopathy, but before the diabetic retinopathy, they have the anti-segment angle changes in form of neovascularization. And those
for the learner it is very difficult, he does not know how to. Then it has to mean that four-mirror does not provide you with an indication moving scope. As soon as you put a little bit of pressure, immediately all the sky of the cornea comes. It's very difficult.
Damage. Before the detection of the early glaucomatous damage, we should look carefully to observe the optic nerve and retinal nerve fiber layer. So a thorough optic nerve examination is very important, and we should correlate the structurally and functionally with the perimetry. Here we have glaucomatous disc damage. There is inferior retinal nerve fiber layer defect which is correlating with superior aqueous defect in the HBF. So how we do the optic disc evaluation? Best we should draw it properly, or we should do the disc photography. So best technique to detect the early change is examining the optic nerve head by high magnification and high intensity light stereoscopic view. We should use slit lamp biomicroscope along with the lens. According to the lens, we have to calculate also the factor. There are 5 rules for assessment of the optic disc in glaucoma. First, we should observe the scleral ring. To identify the limits of the optic disc and size, we should identify the size of the ring. We should examine the retinal nerve fiber layer properly. Also, we should examine the region of parapapillary atrophy, and the most important, not the least, look for the retinal and optic disc hemorrhage. So to identify the ring properly, we should need the direct ophthalmoscope. The size of the light spot is, there are large size disc and small size disc. We should not confuse the large disc with large scope. We should not overdiagnose glaucoma. Also, we should not underdiagnose glaucoma. We should know what is the rim width. It is the distance between the border of the optic disc and the position of the blood vessel bending. Normal optic disc follows the ISNTA rule, in which inferior ring is more thicker and temporal is the thinnest one. While observing the disc, we should observe the thinning of the neuroretinal ring, excavation of the neuroretinal ring, also the notching of the neuroretinal ring. Next, we should look at the color of the disc. We should not go to the color of the disc. We should look in the contour of the disc. Sometimes the pallor is more than the copy, in which we should suspect the non-glaucomatous neuropathy like NAION, toxic neuropathy, or in trauma. Then to evaluate the retinal nerve fiber examination, the best way to see under red-free light. We should look for the striation, brightness and visibility of the parapapillary retinal blood vessels. Normal retinal nerve fiber layer is brighter and striations are good. Here the first picture shows the normal retinal nerve fiber layer and second picture shows there is diffuse retinal nerve fiber layer loss in advanced glaucoma. It is best observed in red-free light. You can see the OS side differs inferiorly. This is the normal picture, this is red-free light picture. Then carefully we should observe the region of the parapupillary area like alpha zone and beta zone. If the beta zone is more, then it is more. If it is not resolving, then we should careful about the disease progression. We should identify the risk factors and other factors which is causing the disease progression. Here picture shows the optic disc hemorrhage inferiorly. Here is the
and go around it, which is not possible in this case because this puncture is very, very peripheral. So you need to still stay well within the margin of the puncture. However, the subsequent step of hydro has to be gentle. If you are too forceful in liberating that jet stream of fluid, it can just extend the puncture just like it happened here. It joins the CCC margin with the puncture, producing a radial tear, which is very, very likely to extend into the posterior capsule. The surgeon here, as stupid as he is not actually helping by manually, forcibly rotating the nucleus either. However, in the next step he learns his mistake. So this is the attempt of paradise regained. So one chop and staying essentially away from the area where the puncture has happened. This can happen to anybody. But remember, if that happens, take out one pie so that the back is relatively free of the nuclear load. Once you take out tip without changing hands into the IA tip. And he successfully does that too, because this is something that is possible to do only when you have an intact capsular back. Sometimes, quite often you see the shallow AC coming in with a small pupil. And it's a general belief that in shallow ACs you should not be implanting pupil expanders. You should be zeroing in on iris hooks to dilate the pupil if such need be. Just to bust that myth, pupil like the pupil expansion devices do. So one by one, of course the last scroll or the last loop has to be engaged bimanually, but that's true for any pupil expansion device, but it does go in and it does get disengaged later too. I'll just build the last part with a case example. This is a post-trab cataract, pretty hard nucleus in one eye, and this is a one-eye patient. The other eye had been lost due to advanced glaucomatous damage. Look at the AQD here, it's 1.52 millimeters and it's a one-eye patient. Herein, I will not be implanting any pupil expansion device, and as a rule, I do not implant pupil expansion devices when there's a PI, and it's a pretty large enough PI because it goes into the eye. It travels more horizontal than oblique. That includes your capsulotomy, which is not that difficult. That includes your hydra cannula, not very difficult again. But it becomes a slightly more challenging when you introduce the phaco needle, because that has to stay more horizontal than oblique. And essentially, you're doing phaco closer to the endothelium than you would have, because this AC is so shallow, it's 1.5. So the trick here is, when you chop the nuclei into pieces, chop is an absolute must. You can't chop these nuclei out to the pupillary plane, because if you do that, you're spending energy very close to the corneal endothelium. And these patients, particularly when you're handling them for the second time, the trap has been performed, the endothelial cell count also is expected to be on the lower side. So look at the way the peeping out with the epices, where the consumption is, or the emulsification is happening. So after all the nucleus is removed, the cortex can be removed, and the IOL can be pushed in. So a few things to keep in mind while you enter, while you do the phaco, and then again while you push in the IOL in a small pupil and a shallow AC in a horizontal fashion, is all that is kept to be kept in mind to handle shallow AC in phaco. Thank you so much for the kind attention.
So you should use iris retractor if you feel that pupil is really small in this kind of situations. So now this is what I would suggest, that before you go in a dry manner, position 0, do this maneuver, and then you will using millimeters of artery essentially. Other machines will know what to write. Now the last piece can create a problem, because there is always a post-operation surge. And if you are not careful, this is more in this eye, not big eyes, not buckled eyes. So you can land up with a PCN. So you should lower your parameter settings, or you should inject OVD. form the eye, and then you come out, or viscoexpress a small chunk of the nucleus. So this is actually, I've just shown this is clear muscle, right? And so basically, this is a special situation, so you need to do it.
Now, we can take one discussion from you, sir. We are lacking time.
The pressure getting the lateral chamber, pushing the iris behind, left side is production syndrome. Maybe my focus was not adequate. So
you said the scleral buckle, the AC depth will not change, but it changes actually. It's the axial length also changes, AC depth also changes, lens position also changes. Because the posterior sclera, it goes backwards. Similarly, the lens position and AC depth goes forwards. There will be some changes are there. The compensation will not.
So he says that maximum axial length, even if there is a 1 millimeter of enlargement of the axial length, hardly any of it is reflected in the anterior chamber there. Now when say most of these Vargen's formulas, it may not be, you may not be familiar with this thing. Most of the Vargen formulas, they calculate the effective lens position depending upon the total axial length and the KLD. Now it is at a more posterior plane. Much more posterior than it really is. So that is the reason we have to make a correction. But that's a very valid point, and I thought my explanation was taken into account.
We will talk on surgical management of post-infant.
Vascular bleb would never regain functionality of the trabeculectomy, and the healthy conjunctiva was mobilized, and then a water on. So with this, my take-home recipe would be a red eye in a post-trabeculectomy patient is never just a red eye. Any bleb that is too thin, cystic and avascular is a... And in the pressure cooker, so in the pressure cooker, we need to be very vigilant and have to take decisions which test our courage.
Why did you do that? Covering the conjunctival graft, putting the chances of breast into his eye.
As a patient, as a one-night patient, I did not want to take risk and...
That is gone. But if you just do not use a sterile pad graft, as I said, just use the conjunctival adjustment, even if the bleb fades later on, you can even do a needling and revive that kind of bleb. So the idea is that...
Next is my topic, and I am Dr. Chandrapur Pujari, and my topic is glaucoma 2025, new insight and evolving therapy. So last decade has been a very exciting period for all glaucoma surgeons, because in the medical therapy paradigm, I will say sustained release systems that reduce dosing frequency and improve adherence. And new drugs have also come. So we have two FDA-approved implants, Thymatopros intradermal implant which is Duista, and Travoplus implant which is Idos here. The thing is, even studies have shown that with Idos here, the patient can go drug free for up to 3 years also. The major concern is contact endothelial loss, and the problem is the patient has to be taken to which is for the same mechanism. But you see the major problem is rho-kinase inhibitor, that is conjunctival hyperemia, is reduced by 28.6%. And we have new molecule also, obligator isopropyl and lactobacillus zero, it is Vigilta, that is already in the market. And now fixed dose combination, letrozole and atrozole is also coming, which reduces the side effect, maintaining the same efficacy. Now in blood medical system, the new thing is institute gel preparation, nanoparticles and neurology, and enhanced pharmaceutical release with improved patient compliance. Now, I always believe that decreasing the IOP is the best neuroprotection, but still we are working on the way on IOP also. But neuroprotection is a challenging thing because multiple pathways are involved, like exotoxicity, oxidative stress, inflammation, and glial cell dysfunction. So the key factors where the glutamate is involved, we have NMDA receptor antagonist, that is memantine, and new molecule also, philantotoxin, P43, microRNA modulations, and RFP1 and ITP MSJ pathways are under negotiation. Now, taking care of the mitochondrial dysfunction, we have created a P2 vitamin E, and where the coated nanoparticles deliver NTCTs here through everyday chamber that enhances penetration into tubular muscle work and stem. Now, stem cell therapy is also called mesenchymal stem cells are evaluated for the safety and efficacy for around 48 months period also. Now we are studying on gene therapy also, which approaches targeting the MIOC and optimum is under pipeline. Now this topic surgical innovation, we have Dr. John, who is the next speaker who is going to speak on detail on this topic. Now the new thing is future direction is AI and personalized care where better outcome. Even genetic profiling is also in pipeline. So, in fundamental analysis, deep models are involved where there is OCT integration and AUC is up to 0.99 which is deadly. And even in scarce data situation also with OCT and FSL, the AUC is 0.8 can predict disease progression also. Like REST snapshot 152 with RNA data, AUC is 0894, AUC is area under the top, and this is 50, the AUC is 0.926. Now, so the road is precision, regeneration and innovation. So the convergence of the advanced drug delivery system, regenerative medicine and personalized approach is transforming dogma from a progressive blinding disease to a manageable condition with preservation.
Medication every day of their life is going to affect their quality of life. So that is why we need mix instead of medication. Why instead of trabeculectomy? It is much faster. So maybe expert surgeons will say trabeculectomy doesn't take much time. But for a junior surgeon, trabeculectomy is going to take a lot of time, lot of sutures, lot of hard work. Mix, it's just go in, cut and come out. So I'm talking about the and there is no risk of hypotony, no blood-related complications, does not damage conjunctiva. That is why instead of trabeculectomy. So from both sides, mix has its advantages. And this is what you do. You find patients who have mild to moderate open angle glaucoma, pseudoexfoliation pigmentia are also very good candidates. And these other criteria are relative, cupping less than 0.8, IOP up to 30. I have done in other patients also, as these are relative indications. 15 initially, but then some patients it rises back to 20. But you can expect to get this range of pressures also. And pseudophakic, phakic doesn't matter. Sometimes I do it in phakic eyes as well. But there are lots of mixed implants, so you have eye stent and different types of eyes called Zen implant, Reserflow. And there are all the implant mix are going to be expensive. The trabecular excision mix are going to be just one device which you have. So bag, you just need a 26 gauge needle. Very, very efficient cost-wise. But KDB Glide is another one which has a dual blade. It cuts very well. GAT, you need suture and just pass the suture through the suture GAT I'm talking about. So suture GAT, you can put a suture through the Schwemm's canal, cut it, very cost efficient that way. And all these other trabectome, HFDAs, you need the devices and then feeling the space. You go in with maybe a dialer, go and see whether your hand-eye coordination in the angle is good. Once that is done, then you start doing, I would say, without an expensive with that, and you want to consider other things. Tanito Micro is the reusable autoclave board, and there is an Indian version also which costs only around 3,000 rupees. So those are all the options. You might have difficulty in positioning the microscope. That is something you will learn. You might have difficulty in holding the lens and the patient's head away from you correctly, and then you will have difficulty in visualization. So I will end with this. Once you start with mix, you can become an angle surgeon. You can do all the surgeries. Very effective or?
Yeah, very effective. we are all desperate to have some new limits of mercury. How accurately we measure and put it into practice. Second thing will be, you said, no, instead of 4 medications, we made it 15.
Some pumpkins in not all patients. But
Thank you all. With this, to the front.
Thank you.